Hello, everyone, and welcome to the Arthritis Action Podcast. I'm Mark, as always, your host, and today I'm joined by Icarus Williams. Icarus is a BABCP accredited therapist and the co-chair of the BABCP Neurodiversity Special Interest Group. Hello, Icarus.
Hi there.
So today we're here to talk about something that I think we might have touched on slightly in the past, but this is something that definitely deserves, an episode of its own and a full discussion around of it. And that's neurodivergence and arthritis. But before we get into that, my intros never do the guest justice. So I would like to give you the opportunity for you to tell us a little bit about yourself and your experience with arthritis.
So my core profession will be as a cognitive behavioral therapist, but within that I have my own specialisms. So I'm also trained in something called acceptance and commitment therapy. And my specialisms are long-term health conditions. So any health condition that comes along for which there isn't a cure or is going to persist or is going to hang around. And also neurodivergence, but particularly the field of sort of neurodiversity affirming therapy. So it's that branch of psychological therapy that is not about deficit narratives and differences from norms and how do we make you fit in and be good and proper. It's more based in the genuine experience of what is a rewarding experience for the neurodivergent person. So from the arthritis perspective, I've been working with long-term health conditions since about 2016. And I moved into a talking therapy service in Bury in Greater Manchester. And my supervisor specialised in long-term health conditions and I got the bug. And since then, as I've progressed on through my therapeutic career and taken on new roles and done more training, long-term health conditions has always come with, and arthritis has always been just one of the most common things we see, and just, absolutely at the heart of that.
Great, excellent. So I suppose let's just jump right in then, because I think there's a few things we should probably clear up off the bat, because I guess, could you explain what neurodivergence is, really? Because I know it's a term's used loads, and I think a lot of people may not quite exactly understand it. So if you could explain, that'd be great.
Yeah, absolutely. So I think you've got the word neurodiversity. And what that means is we all work on slightly different operating systems. No one person can be neurodiverse. It's hard to be a diverse person if it's just you. Diverse in comparison to what? So neurodivergence, the sort of basis of it is that I run on a different operating system to the majority of people. Now, the sort of more old school way of defining this would be to say it's conditions and disorders, like ADHD, autism, dyslexia, dyspraxia, dyscalculia, and it's often based in what we call a deficit narrative. So, normal people are like this, and unfortunately you are like that. So you'll hear things like, reduced empathy, dysfunctions, real sort of descriptions that are, unfortunately you are this way and it's different and wrong. And when we look at it now, we're coming at it from a lot more of a sense of that idea of different operating systems, different sensory processing, different information processing, differences in executive function. But the majority of people who do have those differences are navigating spaces that aren't designed with them in mind, that are designed for the majority way of doing things. So you've got a difference, but you're also navigating a space where that's probably not going to be a welcome way of doing things. That's why you're more likely to hear people say, I am autistic, I am ADHD, I am dyslexic, dyscalculic, dyspraxic.
Because I think a lot of the treatments, especially that come out, are quite often a bit of a one size fits all. This is what you're given, this is how you deal with it. But that assumes a completely straight down the line, most average person you could ever think of, really, doesn't it?
Absolutely. And working in the field of CBT, that's something that's been one of the most common criticisms of it, is that there is an inflexibility there. And fortunately, there doesn't need to be. But when things are built from an evidence base of this is for the general population, and you get to a certain point, we can go, we'll pop a little pork pie hat on top of that and write adapted for ADHD, adapted for autistic people. But there's a question of how far has that work actually gone and been developed before you've considered that genuine experience and what might be a fit for neurodivergent people.
Can there be a difference as to how arthritis can affect neurodivergent people? Is there any sort of physical aspects to this as well?
Yeah, massively. And the core of it is based in that old misunderstanding of, oh, well, someone picked one of the good bodies off the shelf, but unfortunately you got one of the bad brains off the shelf. And that whole thing is kind of inaccurate in every direction. Neurodivergence, we now really understand, is a brain-body operating system. It's not, when you hear words like neuro, you instantly think, brain, mind, psychology, or, neurology. But the neurodivergent body and the way it works throughout those differences. And when it comes to arthritis, there is a real predisposition for neurodivergent people to be disproportionately affected by arthritis for a couple of reasons. So in the sense of osteoarthritis, neurodivergent people are significantly more likely to be hypermobile. Mm-hmm. So about 51% of neurodivergent people are hypermobile. And that's just having hypermobility. You might be able to put your thumb back to your wrist or have a sway back knee or things like that. But then when we get into the idea of what we call symptomatic hypermobility, so that hypermobility is impacting on your health, is maybe causing you pain, is linked to maybe things like something called Ehlers-Danlos syndrome or other hypermobile conditions. Even then, you're looking at a percentage of the sort of high 20s, low 30s, depending on the research you read. So there is a difference in bodily structure going on. But also for the immune-based forms of arthritis, the sort of rheumatoid side of things, there is also a disproportionate likelihood for autoimmune responses and autoimmune conditions in neurodivergent people.
Does that mean things that like rheumatoid arthritis will be more prevalent in people like that as well then?
Yeah, absolutely. And there was a lot of research done into almost trying to find a causal link. As a parent with arthritis, maybe a cause for a child to be autistic or a child to be ADHD, and it's actually, that these things co-occur. It's the brain-body system, and these things do go hand in hand. You might be familiar with stories sort of indicating, maybe paracetamol causes autism. And
yes, I was unsure whether to bring that one up or not, really.
Yeah,
let's talk about it, though. Let's talk about it.
So there were some trends spotted, particularly in some research in Scandinavia, that identified that there were mothers who had rheumatoid arthritis who were maybe having babies who were later identified as autistic or as ADHD. Can you think of a group of people who are disproportionately more likely to have taken paracetamol or have been prescribed corticosteroids during pregnancy?
Exactly. Yeah, that's one thing. It's one of the things that drove me mad when I was hearing about that. It's like, it's not like the data has not been like analyzed in a correct way, has it? No. It's just, there's no qualifiers for anything in there. It's just like a raw data dump. That's what comes out.
This is what happens, I suppose, when anyone approaches any literature with a predetermined idea.
Yes.
And I suppose the predetermined idea of that attempt was to go, there are too many autistic people, and then it's bad to be autistic, and we need to find out why, all these people are being so cursed with this terrible affliction. And it's something very sinister.
Oh, yes.
Within that. There's something, that, and from my own experience as a practitioner who is neurodivergent, it's like I'm over here as on the clinician side of this and the researcher side of this as well. And you're talking about this oppositional group of people. It's like, no, actually, most of my best friends in the field are also neurodivergent, and they're researchers and therapists and physios. Like, there's that separation.
If we move a little bit back, I suppose, towards like how with arthritis, especially, you sort of cover this a little bit, but I'd like to go a bit more into it, really. How different types of neurodivergence, so something like autism, for example, would different types of arthritis affect different people differently?
So one of the things we see as we wander further into this is co-occurrence. And if hypermobility is almost you root into that, within that, there are a whole series of other health conditions that tend to co-occur. And when you start to look into the diagnostic criteria, you see a disproportionate amount of people who are particularly the criteria for being autistic and ADHD who would meet the criteria for both. And the phrase, ADHD or AUDHD has become quite prevalent as a way of kind of going both. Whether it's that those two things co-occurring is really common, one possibility. Another possibility is when those diagnostic criteria were designed, were almost a group of people separated along an arbitrary line, and they may in fact be, a lot more closely related. You'll see research trying to break autism and ADHD down into more and more categories, and you'll see other research going, it's all one thing. So when it comes to the prevalence of the arthritis types, particularly in the osteo side of things, where the prevalence of hypermobility does play quite a significant role.
Yeah.
There's a whole host of other health conditions that tend to co-occur. You've got something called POTS, postural orthostatic tachycardia syndrome, which is a sudden drops in blood pressure that are responded to by sudden bursts of tachycardia to rebuild that pressure. So maybe if someone tilts their head back quite quickly, stands up quite quickly, they go from cold to hot quite quickly. There's a blood pressure shift that comes with that, something called mast cell activation syndrome, which is a histamine response. It's closer to an allergic response. And for the things in there alongside persistent fatigue, what we currently in the UK call MECFS, and also fibromyalgia. These things almost tend to flow together. One of the most common experiences in my practice is I'll have someone come in and they'll say, oh, I've got this, and I've got this, and I've got this, and I've got this. I'm like, yeah, these are things that do co-occur, that we do tend to see come together a lot.
I think that explanation really kind of helps hit home the point, though, because we like to talk about this at the charity a lot as well, about how like your mind and your body are inextricably linked. You can't separate the two. And I think that the way you described it there really does help explain how it can have an effect on your whole body. It's not separate. They're one big unit, really, aren't they?
Yeah, particularly with that real crossover between neurodivergence and hypermobility. Hypermobility is about connective tissue, to steal a phrase from the magnificent Jessica Eccles, and if ever anyone wants to sort of read more about this stuff, she's a magnificent source. Hypermobility based in connective tissue. Connective tissue is like the cling film in the body. It's all the glue and the sellotape and the strandy bits that hold us together. So that includes things like our circulatory system. That includes things like our digestive system, all those, pipes and tubes and collagens. They are all part of that connective tissue. We think of hypermobility and we might think of, doing the splits or maybe being more likely to have dislocations or things like that. And that can is very true for some people. But on a sort of bodily level, that connective tissue is part of everything.
Absolutely. I suppose maybe one thing we should now start to talk about, I suppose, is like the guidance that would be given, because obviously as we've said, one size fits all does not work. I mean, even just for like non-neurodivergent people, one size fits all doesn't work, especially with something like arthritis, because it can affect everyone so differently. What would be, but I suppose there will be some commonalities. So what do you think some of the commonalities and guidance would be for, different perhaps areas of neurodivergence?
I mean, with regards to sort of difference in sort of standardized guidance, it's not there yet. A lot of the research you find will explore the link between two things, but the third thing that would need to be in it maybe isn't in, or there's a big broad study linking stuff together. This is, the brain body stuff is kind of what we're at the forefront of now. This is the research where, if I was referencing it, I'm, referencing papers that were published a couple of months ago, not a couple of decades ago. So with regards to difference in guidance, not a lot, which is a shame, because neurodivergent people are disproportionately more likely to die younger across any cause. Neurodivergent people are about twice more likely to die young from it.
Really? Is that high, is it?
Yeah, it's about twice more likely. And if so there was a big sort of scoping study of this done in 2016. So there could have been some change in the data. But if you were autistic and you didn't have a learning disability, you were likely to die about 16 years earlier than the average person. If you were autistic and you did have a learning disability, you were likely to die about 30 years earlier than the average person.
That is shocking. I didn't realize it was so high as that. I knew that there was some difference, but I didn't realize it was quite so drastic.
Yeah. So when we talk about difference in guidance, that does go across the healthcare service. When we think of what would be potentially useful differences in guidance now, the thing that would really spring to mind would be holistic assessment and multidisciplinary assessment. The rate at which, fibromyalgia, chronic fatigue, POTS, varying types of arthritis, hypermobility, being autistic, ADHD, etc., co-occur. You could spend a lifetime on the waiting list for each and every one of those single tests and never get through. And that works on the assumption that you're aware of them and you've noticed them and that you've got healthcare professionals around you. identifying them. So where the guidance is headed towards is a lot more integrated services and holistic services that you can get neurodivergence assessments and some hypermobility assessments and some other assessments done simultaneously.
Excellent. Well, let's hope that starts to speed along a bit, that's for sure. So I suppose as well as physical differences then, because we've kind of talked a bit about those, what about psychological differences? Because obviously it's, again, back to the brain and body thing, it's going to affect your mind as well as your body when you have something like arthritis. What psychological differences would people experience if they were neurodivergent? I know it's very broad, but if you could break it down as best as you can.
Yeah, I suppose you can split that really into the things that are more genetic and developmental, and then the things that are more likely to occur through that lived experience. In that genetic and developmental side of things, you are going to have differences in things like interoception. So interoception is that sense of what it is like to be us inside is something that's going to be a different experience. And when we're navigating a world where what tastes or feels or smells a certain way is different from the way the majority of people are experiencing it, and going into that more sort of lived experience side of things, you're gonna be told you're wrong. You're going to be corrected. You might feel tired at a time you told you shouldn't be, or not tired at a time you told you should. You might not feel hunger at an expected time. What is or is not painful or distressing or joyous or captivates your attention might be different. And that is something that there can be this sort of constant level of criticism or correction on. I can still remember in childhood being told by someone that water doesn't have a taste. I just going, but it does. And water from a tap tastes different, and cold does and warm does, and the same water will taste different out of a glass than out of a plastic bottle. And that sort of technical side of things, which can be a source of, great joy. We mentioned before I came on, both having a real shared interest in coffee and, to taste things in this really technical kind of way. Absolutely amazing if you're interested in coffee. Absolute nightmare if you have to use an unfamiliar brand of toothpaste. Which it's that lived experience of we actually can become quite familiar with being described with insults, and the idea of being weak, pathetic, oversensitive, slurs related to learning disabilities or your worth. Those can be a very, very familiar thing. And when you find yourself with a body that's telling you this hurts, I am exhausted, I need to rest, they're not the easiest messages to necessarily trust or follow when you're probably quite used to being told those aren't accurate. And within that is, how do we navigate that? One of the things that gets talked about in neurodivergence a lot is masking, which is a look around the world and go, one, I have no idea what the world wants from me. And two, it feels really important I give the world what it wants from me. So sometimes those, genuine feelings, genuine emotions, they don't get to inform our decisions or our behaviors or what we do as much. And that can be intense. And particularly with arthritis, one of the things that can show up with that is the idea of grieving. Working in long-term conditions, you'll maybe be working with people whose bodies don't behave and don't feel like they used to.
Absolutely.
Really distressing, and there's this real sense of grief and of loss. And if, how we do or don't feel about light bulbs and water and, the seams on the inside of socks maybe doesn't get great response. What if our grieving doesn't look right? What if the thing that bothers us about it, or the way we feel it, or the way we show it, doesn't land or get acknowledged? Are people going to think we're fine? Are people going to think we're melodramatic? Are people going to think we're making it up?
It's a really tricky one to kind of balance, isn't it? Like, I think a lot of these problems come, and this is something we get a lot when you just talk about arthritis in general, is that people with no experience of something really struggle to empathize or understand what's going on because they have no reference point themselves. especially with things like mobility or just the ability to do anything when you have arthritis is like, well, why don't you just carry on walking? I physically can't. Like my body's not letting me do this anymore. I'm fatigued or I'm in pain. Only they go, but you're only going a little bit because they have no frame of reference to understand what these things are, I think.
Yeah. And there is in the research into chronic fatigue, which if you want to get into a hot topic, start talking to people who research chronic fatigue.
Oh, I bet, yeah.
So many strong opinions in so many directions.
Fatigue's a really tricky one, isn't it? Because it's completely invisible. You can't see it, and it doesn't. Again, it's one of those things won't make sense to someone who hasn't actually experienced fatigue. It's more than just being, I'm a bit tired. It's nowhere near doing it justice.
So within that, there is absolutely the research into genetic markers and inflammatory responses and autonomic responses, and the psychological experience of it. And is illness involved? Is psychological trauma involved? And really strong opinions of what should be done in every direction. But there does seem to be a thread of just having that interoceptive experience invalidated, of being told, those two foods are the same. You're tired. You're not tired. Just keep going. Just pay attention. Don't do that. It can make that interoceptive experience, which is already different, also just feel less trustworthy. And this is true for doctors and surgeons as well. Personal example. So a few years ago, I had an infection in the small intestine, and I was in the worst abdominal pain of my life. And I went to A&E, and they took me in, did a scan. And when they came with the scan, and it's this, big sort of right angle of inflammation across your abdomen, and they're there going, you should be in agony here. And I'm sitting there going, yeah, this is absolutely horrendous. This is some of the worst pain I've ever been in. I wasn't doubled over on the floor screaming. And it was really hard to communicate that I was like, no, I am in so much pain. This is so intense. I'm almost shutting down a bit and going quiet, and just like, I look like I'm all peaceful and calm with this huge inflamed thing inside me. So for professionals who are trained on, what to look out for in pain or in fatigue or in the way people will respond.
Yeah, even if you look at that pain chart, the pain, like the 1 to 10 pain scale they always give with the little faces on it. Like, unless you're like, red faced and like scrunching your face up, you can't be, they don't look at that bad, do they? But again, everyone reacts differently to it, don't they?
And on that, sometimes you'll see on those charts, they almost try to make it helpful. They'll go, well, we'll put like a stubbed toe here, and we'll put like a broken bone here, or like put a dental infection here, or childbirth here, or we'll try and put layers on. But that assumes a sort of shared objective scale.
I was going to say that feels fraught with its own kind of problems, doesn't it?
Yeah, absolutely. So there is the difficulty sort of psychologically for the individual experiencing it, but also trying to hand that information to a healthcare professional and have it heard or understood when it's almost taken as you talking a different language, and you can quite quickly, feel just not believed.
So I suppose that leads me on very nicely to something I wanted to ask about diagnosis, because that's got to become even more difficult, as you say, like with people experiencing things very differently from what's sort of perceived as the norm. How does diagnosis work in with all that? It must make things much trickier.
So
for diagnosis for arthritis, I should add, just in case anyone's confused.
So without wanting to sort of wander into the sort of the of the rheumatologist and wander out of my sort of long-term health conditions.
Oh yeah, as much as you know, rather, of course.
But there is this, the tests of scans and blood marks and things like that are used. That does go on. I think there's the sense is, how do we get to that point? It's not so much the final test of, is there a scan? Is there a blood test? But communicating what's going on in your body, if it's not being heard, and maybe being told that you're being oversensitive or being told to do something to manage it that isn't a fit for you. The barriers to diagnosis are almost those barriers to getting that appointment in the first place, where you sit and you have the possibility of being heard and being understood and being seen.
Yeah, I suppose unfortunately, even people without neurodivergence, that seems to be the same issues
Yeah.
they really do, I suppose, because people get dismissed far too often.
Mm-hmm.
I'm not trying to like dump on doctors in general here, because of it's just, there's too many like different situations and reasons for all the different types of things. So I'm not throwing shade at any doctors here, but it does happen a lot. People do get not listened to and just dismissed, like, oh, it's just your age, or it's just, no, there's nothing really to worry about. You seem fine.
And as clinicians, from a field that gets its fair amount of shade, and sometimes, I'd say deservedly so, and sometimes maybe some nuance has been lost. If you see a piece of research that says, X percentage of doctors don't understand this, X percentage of therapists don't understand that, every percentage like that can come with, two sides. If it said, even for argument's sake, 99% of therapists don't understand this. Okay, where's the 1%? How do I identify with them? How do I learn with them? How do I be part of that and be included in that? If we see something like that, and our response is to catch the shade from the big number that feels critical of our field, rather than to have that curiosity and enthusiasm and find out what's going in the sort of the section of the percentage that means we've not called it 100, that gap over there, then that's on us. That's part of it.
So what about sort of the treatment? So how would that sort of differ?
So it's about the receiving of either treatment that understands the person in front of them. So one of the main things that gets discussed is physiotherapy, which is a couple of my closest friends are physios, and they're really well up on this stuff. But the amount of physios who recognize things to do with arthritis is quite high. Maybe knowledge of hypermobility or working with neurodivergent people, less so.
Yes, yeah. In general, I'd probably agree with that. Yeah.
Yeah, absolutely. So there was a study done in America on sort of self-reported confidence in physios, and then sort of latter stages they showed them sort of the pictures of the recognizable sort of diagnostic tests, and more than 70% of physios recognize the measures for arthritis, but it was about 30% actually recognized the measures for hypermobility.
Really? Wow.
So when you're doing things in a bodily way with hypermobility, particularly if you're maybe doing sort of more manual therapy where you're manipulating joints, or if you're giving someone a printout of exercises to go away and do, and they make, if they go away and follow that to the letter, have you given something that's helpful for that body?
Would someone who's, I mean, how does someone get to see someone like you when they're when they have arthritis or another long-term condition? How do they get to see you, like, or what, someone of your sort of skill set and training?
In the NHS, we have what are called talking therapist services. They used to be called IAPT, and they are your nationalised, primary mental health care service. There's a postcode search on the NHS website. You type the postcode of your GP surgery into it, and it'll pop up and tell you which one's in your area. And every service is meant to have long-term health conditions within it. But the difference across the country and across services varies really greatly. 2016, moved back to Greater Manchester, started working in the service. My supervisor was a long-term health conditions board, and really enthusiastic and passionate about it, and I caught the bug from him. So it varies from service to service, but every NHS talking therapy service does have long-term health conditions covered within it, just as it does depression, anxiety, PTSD, things like that.
And you can self-refer to these as well, I believe.
Yeah, yeah. The majority you can self-refer. There may be the occasional one or two we have to go through your GP, but I know in my area there's an online self-referral form you fill in and you come in for an assessment.
Excellent. So if anyone out there listening is wondering how you're supposed to get that, you can just do that via the internet, which is always nice when things are able, you can access and refer yourself to them as well. It helps you get a bit more ownership and things like that. Are there any kind of like sort of physical tips you could give for people with neurodivergence and arthritis?
Yeah, so one of the interesting pieces of research done recently is about the idea of proprioception. So that sense of, where we are in space. If we close our eyes, we can still sort of touch our finger to our nose. And in neurodivergent people, there's things like dyspraxia, where there is a different spatial awareness. Sometimes it's persistent, sometimes it's almost more based on connection. Am I interested in this? I can pick up and learn an instrument with great ease. Drinking from a cup, not the most reliable experience for me. And one of the pieces of advice that's sometimes given is that people wear compression socks or compression sleeves. And there's actually now some research that's come out that if we have a difference in proprioception, that sense of compression can actually help ground us and make us feel more connected to the presence of our body. It's the same as you might hear about some people using weighted blankets or weighted hoodies.
Yeah.
Being quite calming and quite soothing. Actually, there can be a double benefit to, obviously don't overuse them, follow the guidance, but some of the compression sleeves and socks and things out there can actually also help with that sort of groundedness and sort of a soothed sense of things sort of related to proprioception.
Wow. I mean, that's especially useful for people with arthritis because, I mean, compression clothing can be incredibly useful already for people with arthritis. So a potential double win.
Yeah, absolutely.
Okay, so I thought let's sort of start to wrap this up a little bit now. Have you got any like final thoughts or wisdom, or like if you were to like give a takeaway as to what you think people should, kind of remember from this, what would it be?
Yeah, so I would say that on an individual level, if there's a phrase in the community, you've met one neurodivergent person, you've met one neurodivergent person. We're as individual and diverse as any other people might be. So when it comes to that idea of rest and recovery, what might actually help, us doing well doesn't necessarily look like someone else doing well. It might not look like a neurotypical person doing well. And the best route really is not about generic recovery at all, and generic rest and generic activities and generic exercises. It's about genuine recovery. When do I genuinely want to sleep? When do I genuinely want to eat? What is genuinely restful for me? Am I tired because I need more sleep, but am I tired because I'm understimulated and I need to have some time that's actually going to be of interest and worthwhileness? Now, for the people supporting others in their lives, getting their own support too, but if I could sort of nail a flag to something and stick a load of big neon arrows pointing at it, it'd be just neurodivergent joy, neurodivergent reward and authenticity and excitement, pleasure and worthwhileness. Neurodivergence is still characterized by distress and difference, and that gets mocked, but we get told they're too much or too full on for getting too excited about coffee or trains or even, socially acceptable interests. Neurodivergent people really interested in football, great social tool for wandering through small talk that we just maybe don't want to have sometimes. But yeah, don't just look to the distress. Look to the actual joy.
Excellent. I think that's a really nice note to end on there. Thank you very much. So for anyone who's been listening, please do subscribe to the podcast as well. Maybe feel free to give us a nice rating as well. The nicer the rating, I believe that'll help people find the episode a bit easier. And if you want any more information on arthritis and some of that type of stuff, you can visit our website. There's a link for that in the episode description. We've also got an email in there as well. So if you've got any further questions or any topics you'd like to hear in future, please do let us know. We always want to hear from you and about whatever you think or whatever you'd like from the podcast. And Icarus, is there anywhere that people should be going for more information on your services?
I would say for anyone really wanting to understand the connection between sort of arthritis, physical health, and neurodivergence, hypermobility, SCDS, Connective, SCDS, are a fantastic organisation. They publish a lot of research. They run a lot of talks, a lot of free video links and stuff. I'd say they're a fantastic source for that kind of information.
Great. And there'll be a link for that in the episode description below as well. So, Icarus, thank you so much. That's been absolutely fascinating. I've really enjoyed that one.
Cheers for having me.
Great. So thank you everyone for listening. And yeah, we'll see you all soon. Thank you very much. Bye-bye.